introduction. If you just give me a second so I can get my stopwatch going. Okay, bring up the very first slide. So this talk is in Vietnamese, so please wish me luck. So what I'm going to be talking on today is screening and diagnosis of malformation during the first trimester of pregnancy. And what I want to do is to give you an understanding of how you perform a scan, and secondly, what you expect to see. Because in 2023, ISUOG issued a new guideline for the first trimester. So we are here in 2024 where we recognize that we can identify the majority of major structural abnormalities in the first trimester of pregnancy. If I could ask, is there a roving mic that you can attach to me? Is there a roving microphone? So, in the first trimester of pregnancy, what I want to do is to demonstrate the importance of having a protocol. Because right at the heart of this talk is having a systematic approach as to how you perform a first trimester scan. And I want to share with you, once my PowerPoint is showing, what the structures are that you need to look at when performing a scan. But if I can say to you that in 2024, the protocol, perfect. The protocol for performing a scan in the first trimester of pregnancy now looks very similar to the second trimester of pregnancy. And if you actually look at the published data, the detection rate of fetal malformation in the first trimester is very similar to the second trimester. I don't think many women want a diagnosis of a major abnormality at 20 weeks. They want a diagnosis in the first trimester. And even for the minor abnormalities, they want a diagnosis in the first trimester because it allows you, it gives you the chance to initiate genetic testing early in the pregnancy. And next door, I spoke this morning about exome sequencing. Exome sequencing for fetal malformation is the future. And it becomes so important to make a diagnosis early in the pregnancy and to phenotype the baby, to make sense of the results you get on exome sequencing. So in Vietnam, in 2024, for the next 10 years, you will be focusing on the first trimester scan between 11 to 14 weeks, because you will learn in a sense to realize that what you see at 20 weeks, you can see at 11 to 14 weeks. Before, everybody would say, oh, the baby's too small. It's smaller than a credit card. A credit card measures 86 millimeters. When you're doing a scan at 13 weeks, it's less than that. That's the size of a fetus at 13 weeks. But with the new technologies, size is not an issue anymore because the organs are all completely formed from the neck down. Malformation from the neck to the feet is the same on a scan for me at 12 to 30 weeks compared to 20 weeks. There's no difference. The brain, from here up, the brain is different. The brain is more challenging, and I will talk about the brain. But we can identify the majority of major structural abnormalities in the brain in the first trimester of pregnancy. So if we look at the scan, ISUOG guidelines, on the left-hand side, this is a minimum standard. And on the right-hand side, that is a dedicated scan. So you have to decide as a doctor, are you somebody who's doing the minimum standard? Are you doing a minimum standard scan? Or are you somebody who's doing a detailed scan? Because you need to understand where you are positioned going forward. What we do in Australia is a little bit different. We offer cell-free DNA at 10 weeks. You know why? Because patients say, I don't want a diagnosis of Down syndrome at 13 weeks or 14 weeks. I want to have the test at 10 weeks. So you can have early genetic testing at 11 weeks. So we offer cell-free DNA at 10 weeks. And you know what the biggest advantage is of doing this? We can precisely time the first trimester scan at 13 to 14 weeks of gestation, 13 weeks of gestation. We do not do a scan at 11 to 14 weeks anymore. 11 to 14 weeks was for the nuchal translucency. But cell-free DNA is a better test than nuchal translucency for Down syndrome and the other chromosome abnormalities. So if that is the case, why do an anatomy scan at 11 weeks? It's difficult. The best thing to do is to do an anatomy at 13 weeks because the detection rate at 13 weeks is better than 12 weeks, which is better than 11 weeks. So we offer cell-free DNA at 10 weeks and we do an anatomical assessment at 13 weeks. And we give half an hour for every booking and we offer to the patients a transabdominal plus a transvaginal scan. Why? Because all the evidence is in the literature that the detection rate of malformation in the first trimester is better if you do both transabdominal and transvaginal. That's why. So we give 30 minutes, they take 2 glasses of water, and we start with a transabdominal scan. It's easier to measure the cran rump length. It is easier to take a nuchal translucency measurement transabdominally. And we do BPD, HC, AC, and FL. And we calculate the biometry and the gestational age. We assess whether single or multiple, and then we screen. The patient signs this consent form. And in this consent form, it says to the patient that the detection rate of malformation is better if you do transabdominal and transvaginal. 97% of all the patients consent to a vaginal scan. That's a very high proportion because most women want to know if there's a major abnormality. When we start the examination, we do a BPD. On the left-hand side is the minimum, doing a BPD and taking a head circumference. On the right-hand side, can I play the video? That's a video. Can I play the video? If you press on the right-hand side, press play. Is there control of the videos on this? No control? Okay, can you play the video on the right long? The video on the right-hand side demonstrates a 4-segment analysis of the brain, and I will be talking about brain malformation in my next talk. Maybe if you can give me a mouse. Can you give me a mouse? Oh, I'm here. Control here. 1 more minute, okay. I think we're loading the videos. So in an assessment of the baby's head, we take 4 segments. What we're looking for is the midline flaps. The choroids should occupy more than 50% of the lateral ventricles. We look for the presence of the cavum velum interpositum. We look for the aqueduct of Sylvius, and we measure the distance between the aqueduct of Sylvius and the occipital bone. And we measure the cerebral 4th ventricle, and we look at the choroid surrounding the roof of the 4th ventricle. When I give my brain talk, I'll explain to you why we do those 4 segments. That's a detailed scan in the first trimester. The next, we look at the sagittal section. On the sagittal section, we measure here the brain stem, we measure here the intracranial translucency, and we measure here, which is the cisterna magna. And here we take the distance from the posterior board of the brainstem to the inner board of the occipital bone as a screening test for spina bifida. So, when you do a scan on Monday morning, you go to work. You do a 4-segment analysis on axial, and on sagittal, you look for 3 black spaces, and this is the largest space, the intermediate size, and the smallest. And then you measure the intracranial translucency and the brainstem to occipital bone distance. If you do that, you will detect 2/3 of major brain malformation in the first trimester of pregnancy. It's that simple. So I want to show you examples of brain malformation. One example of the major ones. I'm jumping between talks here. So this shows you examples of acrania. So if we look in this example here is a fetus. This is a case of a fetus with an example of fetus with an amniotic band syndrome. And when you look at the fetal head, you can see this cystic appearance to the fetal head in the fetus with amniotic band syndrome. And it's an amniotic band syndrome that has caused acrania. This is a fetus with acrania. I don't want to get myself in trouble, but this is called the Trump sign. And you can see the resemblance. This is another form in how acrania may present. This is another example of acrania, and when you look at these images, in all of these cases, the cerebral fourth ventricle is dilated. If you see acrania in the first trimester of pregnancy and the fourth ventricle is dilated, you need to consider that the reason the baby has got acrania is because it has a chromosome abnormality. Digynic triploidy, trisomy 18, trisomy 13. But you may say to me, Simon, that's not important. The baby has acrania. She's not going to continue the pregnancy. It's lethal, incompatible with survival. Well, I say to you, it is important. Because if you know the baby's got a genetic abnormality, such as digynic triploidy or trisomy 13 or 18, our risk of recurrence is very low. But if she has normal chromosomes, her risk of recurrence is 1 in 20 chance that she will have the same problem next time. And I also think it's important for a mother to understand why the baby may be abnormal. But you know, we can pick acrania much earlier than 12 to 13 weeks because we do a scan drawing blood for cell-free DNA. These are examples of acrania at 10 weeks, 9 weeks, and 8 weeks of gestation. And all of these have an abnormal appearance to the cranial end of the embryo. This one has a cystic appearance to it. This one also has a dilated cerebral fourth ventricle. But all of these were evident at 10 weeks of gestation. So in the future, if Vietnam moves to offering cell-free DNA at 10 weeks and anatomy scan at 13 weeks, you will find that when you population screen at 10 weeks, there are abnormalities that you can pick up very early. Moving next to the face. With regard to the face, if you look at this fetus here, there is no jaw. You can pick up micronathia in the first trimester of pregnancy, and look, the nuchal translucency is thin. In fact, for most major abnormalities, the nuchal translucency is thin. You cannot rely on the nuchal translucency as a marker for all abnormalities. The two organ systems with the highest association are skeletal and cardiac. If you look at cardiac, only 1/3 of cardiac present with an increased nuchal translucency. 2/3 do not. This baby has got a thin nuchal translucency and has got no jaw. This is anathia. So you can pick up anathia. You can also pick up more minor degrees. In the next slide I will show you. And this baby has got a bilateral cleft lip and cleft palate. We offer babies with cleft palate genetic testing by CDS in the first trimester, because once you've got cleft lip and palate, you have about a 15 to 20% chance of the genetic basis when it is bilateral. If it is just the lip, it's only 5% you will find a chromosome abnormality. So you can pick up more subtle problems when you look at the face in the first trimester. This is a baby that has got a defect in the hard palate here. I cannot show you because the video is not playing, but if you, are the videos working? Oh, play please. If you can, do I have control? Can I have a mouse to control it? Or here? Yeah, no, there's no control. Can you play the videos? What this video shows is as you go back and forth through the baby's face, you can see that the lip is intact, but the palate is a defect. This is a very difficult diagnosis in the first trimester of pregnancy. In this case, beside it here, you can see that the baby has got micronathia. And again, picking that up at 13 weeks, we would go straight to offering the patient invasive genetic testing by chorion biopsy. In this case here, when you look Here on the left-hand side, you may appreciate the baby has a unilateral cleft lip. The palate is intact. And this shows you a video clip, shows you on 4D. The lips are not fused at 13 weeks, they are open. And if you look with 4D with the cleft, you can see the baby's mouth opening and identify the cleft. The video's gone. We'll just keep going on the still images, okay? Just if you can let me know when the videos are working. In this case here, is a patient at 9 weeks and 6 days. So this is a patient who attended for cell-free DNA. And you can appreciate here that there is a defect in the lip and palate at 9 weeks and 6 days. And this here shows the midline defect. The reason why we picked up the midline defect in this baby because it also has holoprosencephaly. And holoprosencephaly is a very identifiable abnormality at the pre and IPT scan at 10 weeks. So we make this call earlier than the scan at 13 weeks of gestation. But it just shows you the power of ultrasound. And this is a fetus here with cataracts at 10 weeks and 2 days. Cataracts have got a very, very strong association with a genetic basis. So if you ever see cataracts at 10 weeks, at 13 weeks, 20 weeks, is you are looking at offering the patient chromosomal microarray and in the future exome sequencing, because a very high proportion of these will have a genetic basis to the cataracts. You all know about measuring the nuchal translucency. This is something you do routinely in clinical practice, and it's important to continue measuring the nuchal translucency, even though cell-free DNA is a better test for Down syndrome. The nuchal translucency is still important. It's a marker for structural abnormality. You may find when you look at the neck that there are dilated jugular lymphatic sacs. And if you ever see that, you need to consider looking for Turner syndrome, number 1, possibly Down syndrome. And in the future, you will be offering testing by exome sequencing or testing for Noonan syndrome, particularly for those that do not resolve. So there's a strong association with the genetic basis. Then you ask me the question, and you say, Simon, what if you do a scan tomorrow and you see small jugular lymphatic sacs? I would say to you is you need to look and check that the rest of the baby is normal, that the nuchal translucency is thin, and that her cell-free DNA reveals a low result. If the rest of the anatomy is normal, then I have no points of concern regarding this. But I think we need more data on this, because there is a recent publication to say that there is some still additional risk. For these ones here, the patient presenting with an increased nuchal translucency, we noted when we started offering cell-free DNA 10 years ago at 10 weeks, that certain number of the babies presented with increased nuchal translucency. So this is 10 weeks before having blood drawn for cell-free DNA. And we find a nuchal translucency of 3.8. The 97th centile for nuchal translucency at 10 weeks is 2.2 millimeters. This is well above the 97th centile. What we found, and we published in prenatal diagnosis, is that 1% of all pregnancies will present with an increased nuchal translucency. And of those, 25% of them will have a chromosomal abnormality or structural abnormality. So it's a very important finding in drawing blood for cell-free DNA at 10 weeks. You may say, why did Kypros Nicolaides say 11 to 14 weeks? Why did he not say 10 to 14 weeks? If 1% of the population have an increased nuchal translucency and a quarter of these are abnormal, the answer is because back then we were worried about doing early chorion biopsy at 10 weeks and limb defects. And the second reason is 10 weeks is a very hard time to do a transabdominal scan. For these scans at 10 weeks before drawing blood for cell-free DNA, they routinely have a vaginal scan. What about the spine? Well, with the spine, the main reason for examining the spine is spina bifida. So we go to the next slide. So if you look at spina bifida, this is a fetus at 13 weeks with spina bifida, you will find that approximately 30% of spina bifida, you will see the defect in the first trimester by looking at the spine. If you can't see something on spine, then you are relying on the head measurements. And there are 15 indirect head measurements. It is very challenging. Oh, great, you've got the videos going. Thank you. All right, so this here in the top right-hand corner, do I have control here, folks? I don't have control, okay. So down here is the image. You can see this. This shows the spina bifida in this fetus using 3D VCI on the A plane. You can see the meningomyelocele. 80% of babies with a spina bifida will have a meningomyelocele. 20% have a myelocele. And that's extremely difficult to see in the first trimester of pregnancy. You rely on the indirect head signs to show. This is another example looking at the spine of the fetus at 13 weeks of gestation. So if we run the video clip, this is different from what I'm seeing. Oh, this one here. Okay. Thank you. So if we look at this case here, we run through this baby and we see, as we translate through it, is that there's a hemivertebrae. And if you see a hemivertebrae in the first trimester of pregnancy, the next question that I ask is there any evidence of Vater or Vactral syndrome? So it's important to examine the kidneys, look for any evidence of a congenital heart abnormality, and look at the fetal limbs. But what is a very powerful tool in looking at the spine, this is a normal for comparison, what's a very powerful tool in the first trimester of pregnancy is a 3D reconstruction. You will find when you're scanning in the first trimester, if you look at a publication by Valdo Sepulveda, that about 15 to 20% of cases in the first trimester you cannot examine the spine. It's very, very challenging. In this case here, we can play these two clips. Yeah, thank you. As each page we go, just play both clips. Thank you. This is a fetus with a major spinal abnormality with sacral agenesis, and in this case a major anterior abdominal wall defect with a very abnormal deformity of the limbs. So when you're looking at something like this, you're considering the OIES complex, and you also consider the possibility of amniotic band syndrome. In the first trimester, you will have a much higher detection rate of amniotic band syndrome when compared to the second trimester. So it's quite prevalent in the first trimester. And the second thing is make sure you turn up your gain, because that's how you see the amniotic bands. If your gain is not high enough, you will miss them. In terms of looking at the spine, we are picking these up earlier in the pregnancy. So this is at 10 weeks, blood drawn prior to drawing some blood for cell-free DNA. And you can see you have a defect in the lumbar sacral spine. If we look at the now moving to examination of the fetal chest in the first trimester, is it good? Well, it's not good for congenital pulmonary airway malformation. You cannot detect CCAM, congenital cystic adenomatoid malformation. You cannot detect pulmonary sequestration, but you can detect diaphragmatic hernia. And in this case, you appreciate, if we look at the heart is up in the chest, and the heart is in the right hemithorax, and the stomach is up here within the fetal chest. So if you find this diagnosis in the first trimester, the prognosis is much worse when compared to making a diagnosis in the second trimester of pregnancy. So it's important to look for this because it becomes very important in counseling patients with congenital diaphragmatic hernia, and some of these may present with the linctus lucis. So many patients who have this diagnosis of congenital diaphragmatic hernia in the first trimester of pregnancy, because they know that the perinatal mortality rate is 60%, some patients choose not to continue. The other thing you may see in the chest is bilateral hydrothoraces. So you can see you've got fluid on both sides, and this is a 3D tomographic ultrasound slices showing bilateral hydrothoraces in a fetus with trisomy 21. And we know in mid-trimester, seeing a hydrothorax, you think of trisomy 21. See in the first trimester, you think the same thing. If you ever see bilateral pleural effusions, and this is very early in a 9 to 10 week pregnancy, always consider the possibility of cardiac extubation. So this is a very important diagnosis to make very early because it carries a terrible prognosis. But this is made at 8 to 9 weeks, and it's a very straightforward diagnosis at 10 weeks of gestation. So I gave a talk on the heart this morning. So I will be quick with this because many of you will have attended that talk. But let me show you. That is a picture of the ultrasound machine that I started with. It's called an Axon XP4, and these are the images. Can you run the top video clip, please? This is an image taken from, let me look at the date on the scan. This is an image taken from 1997. That shows you how old I am. And you can see that the left cardiac ventricle is significantly smaller when compared to the right. This was a fetus with a hypoplastic left heart back in 1997. So where are we today? Today we're looking at this sort of image. That's showing a 4-chamber view of heart, a 3-vessel tracheal view, and a 4D reconstruction. The detail of what the heart looks like today is very different from what it looked like back 25 years ago. And the point I made this morning is we can identify 2/3 of major cardiac abnormalities at this stage. If we go to the next slide. So these are the publications, and I'll be very quick on this, but this is the publications going from 2011 to 13 up to 2019, showing that the detection rate of cardiac abnormality is increasing every time we go to publish. And 2/3 of major cardiac abnormalities can now be identified in the first trimester. Just run the clips very quickly. I'm going to go through this quickly just because I covered it this morning, but this is a hypoplastic right heart. This is a VSD, the hypoplastic right heart, and tricuspid atresia. This is a case of Epstein's anomaly with enlargement of the right atrium. This is a 3D reconstruction of a common arterial trunk arising from the right ventricle. This is an AV canal defect, and this is a double inlet left ventricle with transposed great arteries. 6 major abnormalities, all detected in the first trimester of pregnancy. And that allowed us to do chorionic biopsy and get early genetic diagnosis. Next page, please. That's major cardiac abnormalities. If we look to the next page, we see minor cardiac abnormalities. And just run over the clips, please. This is a baby with a right aortic arch, and when you look at the aortic arch, it splits here. It's a double aortic arch at 12 weeks. If I see a double aortic arch at 12 weeks, I want to know, does the baby have 22 q deletion? So the next thing I look at the baby's face to see if there's a facial cleft. I look to see if there's an increased nuchal translucence. I look to see if there's an associated abnormality, and I offer genetic testing. This is an example here of a right aortic arch. This is a aberrant left subclavian artery, and this is an absent ductus venosus. All of these minor cardiac abnormalities have an association with a genetic abnormality, and first trimester diagnosis allows you to offer genetic testing. If we look at this even earlier in pregnancy at 6 to 10 weeks, this is a cardiac abnormality in an embryo that measures 7 weeks and 6 days. And if you look at the cardiac pulsation, it's outside the embryo. And you will also note that there is no cranial end. The fetus has acrania and cardiac extra. And this is as early as 7 weeks of gestation. And this is a conjoined twin pregnancy at 7 weeks of gestation. So a single cardiac chamber with 2 embryos seen very, very early in the pregnancy. This is a patient I saw 2 or 3 weeks ago on the 4th of April. And when you look at this embryo, you can appreciate that the cardiac pulsation is outside the embryo. This is cardiac extrophy at 7 weeks, and you can also appreciate that the cranial end of the embryo is abnormal. 1, it's irregular. 2, it has an abnormal shape. And 3, the cranial vesicles are abnormal. This is a case of a crania and cardiac extrophy between 7 to 8 weeks of gestation. So next, let's move to the first trimester evaluation, looking at the genitourinary tract. What can you pick in the genitourinary tract? And the answer is lower urinary tract obstruction. The detection rate of posterior urethral valve syndrome in the first trimester of pregnancy is close to 100%. It is, from a patient's point of view, they want this diagnosis at 12 or 30 weeks. They do not want the diagnosis at 20 weeks of gestation. In this case, you've got a borderline increased nuchal translucency. And some of them will have an increased nuchal translucency because they're associated with Down syndrome 13 and 18. You can do a 3D render, and in some of these you can see the rugae within the fetal bladder, but it's a very detectable problem. That's straightforward. These are more difficult. This shows an example of normal kidneys. And the first thing you see with normal kidneys at 12 to 13 weeks is they are very bright. They are hyperechoic. Don't make a mistake of calling hyperechogenic kidneys at 12 to 13 weeks, because the kidneys don't filter much urine. In this case, in the bottom right-hand corner, you see there's a duplex system. Now, I don't worry about a duplex system if that's the only problem. But if the baby has a duplex system and an aberrant subclavian artery or some other marker, then I will offer invasive genetic testing. In the top left-hand corner, this is the features with the horseshoe kidney. And in this case, it's the features with an absent or an absent kidney. So one kidney here, absent kidney. If I see a horseshoe kidney, that has got strong association with a genetic abnormality. If it's isolated, single kidney missing or renal genesis, I'm not so worried. But I will go ahead and examine for Vactral, for features of genitourinary tract abnormality. The next system is the gut. So in the gastrointestinal tract, you can see bowel dilatation in the small bowel of this baby. Increased bowel echo texture, dilated loops of bowel, increased peristalsis. All the three things that we rely on at 18 to 20 weeks are present in the first trimester of pregnancy. It's a certain diagnosis. In this case, it's anorectal atresia, so it's the large bowel. But only a small proportion of bowel obstruction will present in the first trimester, approximately 1/3. Many of these, in fact, don't present in the second trimester, they actually present in the third trimester, or indeed after birth. But there is a proportion you can pick up in the first trimester. Next is the abdominal wall. These abnormalities, omphalocele and gastroschisis, are detectable in 100% of babies in the first trimester of pregnancy. It's a very detectable problem. So in this case, if you run these clips, this is the fetus with gastroschisis. You can see with slow flow technology, you can follow the superior mesenteric artery and you can track it from the origin, from the celiac axis into the gastroschisis. And you see loops of bowel floating freely in the amniotic fluid. If you ever see a gastroschisis in the first trimester of pregnancy, make sure you're not looking at a cloacal extravasation. It may be more complicated than you think. And when you see an anterior abdominal wall defect in the first trimester, you are going to offer genetic testing, because omphalocele is one of those abnormalities that has a very strong association with aneuploidy. When you use 3D, you can use 3D to see the hyperechogenic bowel inferiorly and the liver superiorly. It may get more complicated. So in this case here, you see an anterior abdominal wall defect. You also see multiple loops of bowel. There's no visible bladder, and this is the fetus with cloacal extravasation. This is not a gastroschisis. This is not an omphalocele. It is far more complicated. It's a cloacal extravasation. And the next step I ask myself is what does the spine look like? Is it part of an OIES complex? These are challengingly very difficult to repair. And this is a cloacal cyst in a fetus with another cloacal abnormality. Again, look at the spine. These are major abnormalities in the first trimester. Another case with a short, sometimes called the short cord syndrome. But when you look at this, you see the cord is very, very short. It originates here and goes straight to the baby. And you have very abnormal positioning of the limbs. This seeing a short cord syndrome crosses over with the cloacal extravasation or body stalk anomalies, and are generally very serious abnormalities. But can I tell you that while it's very straightforward to make a diagnosis of an anterior abdominal wall defect at 12 to 13 weeks of gestation, we actually see it even earlier because we do cell-free DNA at 10 weeks. And this is the features at 10 weeks of gestation with an anterior abdominal wall defect, and this is the same patient coming back later for CDS. So you may see them earlier, but be careful to not confuse them with a physiological herniation. The last system is the skeletal system. How good is the first trimester in the skeletal system? Here you have a picture of showing the hands, you show the fingers, and count the digits. It is much easier to count the digits on the hand when compared to counting the digits on the baby's feet. If you actually look at what the detection rate is for skeletal abnormalities is pretty good in the first trimester for focal abnormalities. And I think that the first trimester of pregnancy is the best time of any stage during pregnancy to pick up focal limb abnormalities. A missing hand, a missing forearm, a missing limb, transverse limb defects, radial ray defects, polydactylies. If you look at the first trimester of pregnancy, for me, because in the second trimester, trying to have the same hand twice position the baby's in, but you won't make that mistake at 12 and 13 weeks of gestation. Examples, I don't know the video clips. This is a feature with hand polydactyly, foot polydactyly, foot ectorodactyly, hand oligodactyly, hand oligodactyly, hand oligosyndactyly. All of these have association with genetic syndromes and genetic abnormalities. And you can identify these in the first trimester of pregnancy. If you see ectrodactyly of the baby's feet, or if you see ectrodactyly of the hands, the next step is then to go and examine the fetal face. Then run these clips. These are all transverse limb defects. I think everybody in this room will recognize these abnormalities when you go to work, if you see this tomorrow morning. Because the proportion of fluid to fetus is highest at this stage in gestation. In fact, it's even easier at 10 weeks to find a missing hand, or a missing arm, or a missing leg, or radial ray deformity. These are very identifiable abnormalities in the first trimester. And why do I show you this clip? Tell me what's the problem. This is showing a transvaginal scan, and this is showing a transabdominal scan. They both show the same thing. One hand has got polydactyly, postaxial polydactyly. But it was very difficult to see this, a transabdominal scan, but so easy to see it. Here's the extra digit. Thumb. 1, 2, 3, 4, 5, and here's the extra digit. But that is much easier to see with a transvaginal scan when compared to a transabdominal scan. If it's an isolated finding and there's nothing else to go with it, it's a very low association with genetic abnormality. Unilateral, isolated, postaxial polydactyly tends to run in families, and it's a benign finding. We can pick them up even earlier, and this is at 10 weeks. This is a fetus with 9 weeks with postaxial polydactyly, but that was not the first thing we saw. The baby also has holoprosencephaly. So if it has polydactyly and holoprosencephaly, it has trisomy 13. This one here is polydactyly as well, but it's at the feet. And this is part of an OIES complex, and that's a much more difficult or challenging diagnosis. This is ectrodactyly. So this is at 6 to 10 weeks of gestation, and you can see ectrodactyly. If I see ectrodactyly, the first thing I look at next is the fetal face, because I want to know, is there clefting? Is it part of ectrodactyly ectodermal syndrome? And after that, I do a target assessment of the rest of the fetus. But it has a strong association with any problem. The next and last section is genitalia. Do we look at the sex of the baby at 13 or 11 to 14 weeks? The answer to that question is you need to be extremely careful, because you might get it wrong. Especially at 11 weeks. I would not sex the baby at 11 weeks. 12 weeks, be careful, but your detection rate at 13 weeks is very good. Where the male fetus points upwards and the female fetus points downwards. So this is female and this is male. And various people have reported angles. I don't find that helpful. I just like subjective assessment. And you say, Simon, why is that important to look at sex at 13 weeks? Because when the patient comes to me, I have the result of the cell-free DNA. And if the cell-free DNA says baby girl, and I do a scan and I see a baby boy, well then I've got a problem in my hands, and I need to investigate for ambiguous genitalia. That's why. And that's the advantage of having cell-free DNA at 10 weeks, is when you have a scan done, you can work out what the sex disorder is. There are other reasons, in terms of X-linked hydrocephalus and other structural abnormalities, which I like to do. Lastly, the umbilical cord. You see cysts on the umbilical cord, you ask the question, Simon, do you worry about cysts in the umbilical cord? I'll say to you, well, it depends when you do the scan. You do the the scan at 10 weeks and see umbilical cord cysts, I don't worry at 10 weeks because they're gone by 13 weeks. If I see cord cysts at 13 weeks, I'm still not worried because most of them will be gone by 20 weeks. But it's very important to look at the anterior abdominal wall. Make sure there's not an fallacy. Make sure there's not an associated abnormality. So if you do see a cord cyst, check closely, especially the anterior abdominal wall. And if there's nothing, they go away by 20 weeks of gestation. So what difference is this talk going to make to you when you go to work tomorrow morning? Well, the first is, I suggest that's the most important slide, because what that slide says is these are all the structures that I'm going to measure and that I'm going to look at doing a routine scan during the first semester of pregnancy. That's the first thing. So this is you go to work, and this is your scan. And I'm going to walk you through your scan and play the clip. First you do 4 sections. Next you look at the 3 black spaces. Then you split, showing the maxilla and the mandible. Then you split, you show the right and the left hand. Then you do a sagittal section, you show the diaphragm. Then you show the heart with the 4 chamber and the 3 vessel tracheal humor. Next page. Then you go on to play the clips, please. Then you go on, you look for the presence of both kidneys. You look for the presence of 3 vessel umbilical cord. You establish the stomach is present, you check the spine, you split the image showing the right and the left arms, and then you look at the placenta. This baby's got digynium tripod. You look at the placenta, the cervix, and the adnexa. In those 2 video clips, you have fulfilled the protocol of the ISIOR guidelines in 2023. And if you do that, you will identify more than 65% of major structural abnormalities. Your detection rate becomes close to the detection rate at 18 to 20 weeks of gestation. So where do I think this is all going in the future? I think it becomes absolutely critical. Because we know with fetal malformation that for the last 25 to 30 years, we have been searching for chromosomal abnormalities as a cause for a structural defect. And what is the prevalence of chromosomal abnormalities as a structural defect? The answer is about 6%. But if you look at exome sequencing and monogenic disorders, it's higher. It's around 7%. There is no question that the future for the next 10 to 20 years is going to rest on exome sequencing in the exome sequencing prenatally. And it's going to move earlier and earlier because the time it takes to do a FISH, to do a chromosomal migrate, to do an exome sequencing is so long in 2024. I know it will improve, and I know we will move to whole genome sequencing. But look at this slide. This is where many countries are today. They are doing a scan at 12 to 13 weeks and measuring a nuclear translucency and maybe a little bit of anatomy, but they're really doing the anatomy scan at 20 weeks, and then what they're doing is they're offering an amniocentesis when there's a problem. They're getting a chromosomal microarray at 23, and then they're doing exome sequencing at 26. That is what is happening across the globe in first world countries, premier service countries. That's what's happening today. What do I think is going to happen? I think cell-free DNA will become a standard because every woman wants to know at 10 weeks whether her baby's Down syndrome or not. She doesn't want to know 13 weeks. You ask her. And if you find a problem on your cell-free DNA, if it says baby's got Down syndrome, you can do a chorion biopsy at 11 weeks. Not at 13 or 14 weeks, at 11 weeks. And then once you've got the CBS, if it shows a problem, there's no problem on the CMA, you have exome sequencing by 18 weeks. That for me is the future. That for me is an inevitability of what's going to happen in prenatal screening, and I think an inevitability in the sense of what will happen to Vietnam in the future. I think I've gone way over my time. I've lost track of my time, but thank you very much for your attention.